Afternoon, and thank you for joining us for today's Rare Cancer Day webinar on breaking down barriers to diagnosis, treatment, and research. This webinar is part of NORD's free series of educational webinars for patients and caregivers. Hi, my name is John Hopper, and together with Jim Palma, I'm the co-chair of NORD's Rare Cancer Coalition. It is my pleasure to be the moderator for today's event. Before we get started, I would like to provide a brief word about NORD's Rare Cancer Coalition. The Rare Cancer Coalition unites more than 24 NORD member organizations working in rare cancers to collaborate on issues facing the greater rare cancer community. The coalition strengthens its individual members through capacity building, networking, and peer-to-peer mentoring. We're thrilled to be part of the 2021 Rare Cancer Day activities. Next, I'm also excited to announce the registration for the NORD Virtual Rare Disease and Orphan Products Breakthrough Summit is open now. The summit is one of the largest multi-stakeholder events in the rare disease community. The two-day event brings together members of the rare disease community, including rare disease experts and leaders from patient advocacy groups, government, industry, and academia. This year's program includes a session on advancing rare cancer awareness and education among healthcare professionals. To see the full agenda and register, visit nordsummit.org. That's NORDSUMMIT.org. Before we begin, I'd like to briefly introduce today's panelists. First, we will hear from Dr. Simran Singh, a medical oncologist at the Odette Cancer Center. Next, we will hear from Dr. Margarita Vergata, a research geneticist and oncology genetic counselor at the National Institutes of Health, National Cancer Institute. And last but not least, Rob Taylor, a rare cancer patient and advocate, will round out the panel. Now, it's my pleasure to turn this over to each panelist to provide some introductory remarks. Dr. Singh, would you start us off?
Yes, thank you very much, first of all, for having me here.
I'm a medical oncologist at the University of Toronto at the Odette Cancer Center. And in Canada, we have a primarily public healthcare system. So I focus a lot on neuroendocrine cancers, which can be considered an uncommon or a rare cancer. There's a lot of challenges in ensuring patients have the right access and ensuring equity in treatment for people who have rare or uncommon cancers. So when we're talking about these diseases, and specifically in my case, when we talk about neuroendocrine cancers, we're talking about issues of awareness. Often there is an awareness both in the medical community, but also in the healthcare system overall, and among our primary care colleagues about these less well-known cancers. Diagnosis is a large issue. We have a well-documented diagnosis delay for patients who have neuroendocrine cancer, and this exists irregardless of country or even health system. It's estimated now that diagnostic delay is around 7 years, which can be very long for patients in certain situations. Then we have issues around testing and treatment. This is a particular problem, especially in reimbursement or in public healthcare systems, because often the systems are designed for more common cancers such as breast cancer, colon cancer, prostate cancer. And to be reimbursed for either testing or for treatment, they require a certain level of evidence that exists in the system. That can be a real challenge for less common or rare cancers like neuroendocrine cancer, and that often leads to problems in access and equity. Now in Canada, like the United States, we have a very large area, and we cannot provide care to all the rare cancers in every institution. So we have centers of excellence and centers of expertise. What we do struggle to do, and what we do need to continue to work to do, is to ensure that patients who are in rural settings and in urban settings can all get access and equity to the appropriate care for this type of cancer. We did studies looking here in Ontario where we did find that, in fact, there was a survival difference between patients with neuroendocrine cancers in rural settings and urban settings. And that caused us to set up a cancer clinic here for neuroendocrine cancers called the Susan Leslie Clinic for Neuroendocrine Cancers. The goal of this was to have a patient-centered approach, so the care revolved around the patient. and that was to help us make sure that we have access for all our patients, both urban, rural, regardless of where they come, so that they can be seen in a one-stop shop. There's still many issues that exist for many rare cancers, things like language. We have a very multicultural population in Canada, and especially in Toronto. Socioeconomic status. These are all really important factors that need to come into place when we're talking about rare cancers. I had, for example, a patient who had a large diagnostic delay. She was seen in multiple centers over and over. She had very typical symptoms of the cancer, but this wasn't recognized. And being a new immigrant to Canada, she didn't know the healthcare system as well and had a large diagnostic delay. Finally, she reached our clinic and we were able to help her, but her experience certainly was one that we do not want in general for any patient with rare cancer anywhere. So how do we approach this issue? I think the approach is really taking a patient-centered approach. We need to work with patients, with our patient advocates, and work together globally to be able to raise awareness of rare cancers, to be able to ensure that we get the right testing and treatment for rare cancers, which can be difficult, and ensure that we have the tools that we have to deal with the access and equity issues. One of the ways we've done this, for example, in Canada, is we've formed a cooperation between Australia and New Zealand and formed an organization called COMNETS, which is a Commonwealth Neuroendocrine Tumor Society. And this really means we've been working together with patients in these three areas with all primary public healthcare systems to ensure that we have access to all our population for rare cancers, in this case specifically neuroendocrine cancers. So that's really where my focus is on, is to ensure that we raise awareness and that we have the right treatments for our patients so they get the right treatment at the right time. Thank you.
Great. Thank you so much, Dr. Singh. Dr. Regatta, some comments from you, please.
Yes, thank you, John, and thank you for inviting me. I am so happy for the opportunity to be able to participate in this webinar, but especially to be able to connect to so many rare cancer patients today. My name, as you said, is Margarita Regatta. I am a research geneticist and cancer genetic counselor at the National Cancer Institute at NIH. I have been at the NIH for more than 20 years and been working on cancer genetics for most of my professional life. My particular research interest is in delineating the genetic basis of rare conditions or rare cancers, actually, and to identify the associated phenotypes and common molecular pathways, with the hope that we can find common etiologies for both the phenotype and the tumors, and that in the future may help us improve care for rare cancer patients. So I wanted to mention at the National Cancer Institute, we have recently, in the past 2 to 3 years, designed a comprehensive longitudinal study and clinical trial for rare cancers. This is a long-term study that covers several aspects and integrates several aspects of rare tumors, including biochemical, molecular, genetics, and psychosocial. Under this protocol, we look at every patient in detail and look at the patient, the tumor, and the family. This is a federally funded initiative, and it's part of the Cancer Moonshot Initiative, which originated in the 21st Century Cures Act that was passed by Congress in 2016. Examples of tumors that we see under this protocol are leiomyosarcomas, pheochromocytomas, GIST, chordomas, and also rare brain tumors. In fact, we have two main groups in this initiative. One is the neuro-oncology branch, where we see rare brain tumors, and the other one is the pediatric oncology branch, where we see pediatric, adolescent, and adult rare cancer patients. All patients are followed and evaluated free of charge. In keeping with the main theme of this webinar today, which is access to health care, or in my particular case, access to genetic care, I believe that the best way that we can address the challenges that rare cancer patients face is by helping them understand the genetic basis of their cancers and educating them on how they can use this information to manage their tumors so that that may decrease the risk associated with the mutations they carry and the tumors they have. Now, all cancers, including rare cancers, can occur in two ways: sporadic, which is the most common way, or inherited. When the tumors occur sporadic, it happens out of the blue because a somatic mutation has occurred in the tissue that's affected. When tumors occur inherited, they're part of a hereditary cancer condition, whether it's known or unknown, or it has a hereditary component. Regardless of the etiology, it is important that we identify these two types of patients so that we can provide and establish the appropriate management plan, treatment, and preventive care. In the past 5 or so years, genomic medicine has revolutionized the way that we treat cancer, and it actually has revolutionized the cancer world. These advances are now being used as tools for rare cancer patients, and thanks to genomic medicine and the advent of personalized medicines, we can now offer rare cancer patients opportunities to participate in new research clinical trials, and also, and more importantly, additional options for treatment. And I look forward today to discussing this in more detail. Thank you.
Thanks so much, Margarita. That's really interesting, and I already have a lot of questions for you after this. Rob Taylor, so here we have an oncologist that just spoke, a genetic counselor, geneticist. You're walking the walk, my friend, and I think we'd love to hear more about your story and then how you personally and the patient advocates that you work with look at these whole barriers of diagnosis and entry, et cetera. So, Rob, please share with us.
Well, first of all, I'm just honored to be a part of the group, and my take on this is that first of all, is that we as cancer patients have to advocate for ourselves. I was diagnosed in 2006. The doctor that I was going to told me that I'd probably only live 9 months. And I almost believed him. And I was very, very fortunate because with all the going back and forth, I was kind of depressed. And someone told me to join a group, join a help group for cancer. And given the guy I am, I'm like, I'm not joining one. But eventually I joined the Raft group, and it was really, really a blessing because the first thing they said, well, you need to get another opinion. And they gave me a doctor that was a specialist in my form of cancer. They also worked in getting genetic testing, getting mutational testing, and just had me on the move. I was really, really busy trying to help myself. And they even did research, read publications to where they found something that would work for me, because before, with the kind of gist I had, there was no medication for it. So joining the group, and joining the people that are committed to helping those with GIST and rare cancers blessed my life. Really, really, really blessed my life. So that's the first thing that I would say, is that you have to advocate for yourself, because there's barriers. There's some of those in rural areas, their doctors have loads of patients. So they really don't have the time to concentrate, to do all the things that some of the other doctors might have. So the issue is the doctor might not be as educated on your type of cancer. So you have to seek out a specialist that deals with your kind of cancer, and one that might have the time to do the research, maybe at a university or something like that. So there's a lot of onus on the patient to do what you have to do to make things work, to read publications. I couldn't read or understand publications prior to getting sick. Once I got sick, and the Life Raft group was sending publications, and eventually I had to read them and understand them. So do what you have to do in order to fight for yourself. Join support groups that will help you. Do as much reading as you can. Ask for help. The patients that I run into, there's some that don't trust doctors at all. Given the history of some of the experiments with African Americans, there's a lot of African Americans don't trust doctors. There's a lot of women that do not trust doctors because they look at the statistics and see that women with certain cancers die more than others. So they're saying, well, they're not getting the right treatment, so they don't trust doctors. So there's a lot of relational barriers that have to do with the success rate of those in rural areas and minorities. There's trust. There's some have given up hope. So we patients have to fight the fight, and do we have to do in order to win this battle. Thank you.
Thanks so much, Rob. And it's really great to hear your journey. I'm going to start with some questions, if I may, to the panel here. Simran, Rob was just talking about some of the barriers that happen and the trust that a patient has with an oncologist or whoever the first person diagnosed him with that. And it kind of goes along to the question to get diagnosed. So start off with that. And then if you could also just comment on what Rob was saying about your experience about the interaction with patients and those who seem to be hesitant to relate to the physician.
Sure. Sorry, I missed that first part. I got the second part of your question. I just missed the first part of your question and cut out there just a bit.
So sure. So two parts. One would be, why does it take so long for many rare cancer patients to get diagnosed? And the second part was relating to one of Rob's comments, was that in certain communities, there's a lack of trust with physicians and oncologists. And is that a factor that you see in terms of perhaps one of the reasons why it takes so long to diagnose a rare cancer patient? So two parts, if that makes sense.
Sure, thanks. So for the first part about the diagnostic delay, I mean, this is an issue that affects many rare cancers. And the reason for this is really awareness. Many people, aren't taught about these rare cancers, or it's simply not part of their normal activities from day to day. As the previous speaker was saying, they may not be experienced with this. For example, I deal with neuroendocrine cancers. I believe I'm the only one in the country that specifically only devotes my entire practice to this. But there may be many people who are going to see one or two in their whole entire lifetime of their career. So how do we go beyond that? Because there's practical things as well. I mean, not every doctor can be aware of every disease, but we can work together. And I think the big part of that is working together with patients and with advocacy groups like the Life Raft group and other groups to raise awareness and to make sure that people have it on their mind, or at least think about it, or at least know where to go. So one thing we've done is, for example, building a training program. So we have all our trainees come through here. So at least they're aware of neuroendocrine cancers. And when they go practice somewhere else, for example, they know, oh yes, at the University of Toronto, we have this expertise in this type of cancer. So when I see a patient, this is where I should refer them, or this is where, if this is on my suspicion list, this is where they should go. So we create a network. So both building a network among healthcare professionals and building a network and a team partnership with patients. The second part of the question is very true. I mean, the most of the people we see at our clinic in terms of diagnosis have already been through the system. I had, as I was mentioning in my introductory statements, I had a patient who presented with symptoms of flushing and diarrhea, which can be common symptoms for neuroendocrine cancer. She had recently immigrated to the country. She was diagnosed with having an adjustment disorder and then actually ended up seeing a psychiatrist. And these were real symptoms that were the manifestation of her rare cancer. So by the time she got to us, you can imagine she was frustrated, she was rattled by the medical system, and she was certainly looking for care. So again, it comes to a case of communication, of partnership, of working together, but of listening. I think it's really important for oncologists to listen to their patients and to work together to try to understand and get over some of the barriers that were described.
Great. Thank you so much. Margarita, some questions for you. One is just kind of a basic definition, I think, that patients would like to know. So what's the difference between genomics and genetics?
Yeah, sure. I get that question all the time. And unfortunately, the terms genetic and genomic are sometimes and often used interchangeably. Unfortunately, also, you can find different definitions for each in the internet or in genetic websites. So I'm going to give you some examples. One definition for genetics is that it has to do with genes and traits that are being passed on from one generation to another. One definition for genomics is that it has to do with all the genes in an individual, so the whole genome. And there's also another definition that genomics describes the person's somatic mutations and genetic describes the normal cells. So, but in summary, the most agreed upon definition of genetic and genomics is that genetics has to do with the testing of normal cells and normal genes. And then genomic has to do with the testing of somatic or tumor testing. So a way to remember would be genetics is genes, normal or inherited. Genomics is somatic tumor testing. That is the most easy way to remember, the easiest way to remember.
Thank you. And a follow-up question for you. So go back to what the importance of genetic versus genomic testing is in cancer and the role of a counselor. So if someone seeks a counselor, is told to, how is that approached and the importance of it and how does that guide a patient?
Okay, so we'll start with the importance of genomic and genetic testing in rare cancers. So genomic testing, and I think Mr. Taylor touched upon how important for him was that once he found genetic testing, then he received more guidance into his tumor. And that is true. So genomic testing is important for diagnosis and treatment of tumors. Genetic testing is important for prevention of cancer. So in terms of diagnosis, rare cancers or rare tumors are often very difficult to diagnose and often even misdiagnosed. Why? Because the pathologists and the pathology team and the oncologists, as Dr. Singh was mentioning, have seen very few of these types of tumors. And this is when it's important, as Dr. Singh was saying, to go to a center that specializes in these tumors. I have seen many of them. But genomic testing comes into play because it can help physicians, it can guide physicians into making or achieving the right diagnosis by further characterizing the molecular profile of the tumor. So every rare cancer patient should have a molecular profile of their tumor at least once. And that is my first take-home message. In fact, most rare cancer patients have molecular testing at different stages of the disease. And these molecular tests have different names. They can be somatic panel, molecular tumor profile, and they are performed by different commercial labs, and they all give different names. They cover different genes or groups of genes, and they're used to answer different questions. But these molecular partners also have another important use, and they're important for providing additional target therapies for rare tumors when standard of care like chemotherapy and radiation has been exhausted. And so So I think that answers the first part of your question. What was the second part?
It was more about the role of the genetic counselor and how do people actually find a genetic counselor, et cetera.
Okay, so the role of the genetic counselor, as I said before, there's two ways that rare cancers can occur: sporadic or inherited. Genetic counselors, the role of the genetic counselor is to give information to patients with rare tumors so that they can use this information to make informed decisions about their treatments, their prevention, and their care. So genetic counseling is a long-term commitment. First, we meet with the patient in order to evaluate the family history, the medical history, and the type of cancer that the patient has. And then we assess whether the tumor has a hereditary component. If the tumor has a hereditary component, then we offer genetic testing as opposed to genomic testing, and then educate the patient on the implications of the results and advise them on how to prevent further, how to test relatives, and how to implement a management and a new surveillance plan. And with regard to the tumor, we offer genomic testing and then educate the patient on the results of the panel so that they can make decisions on their treatment and approach their targeted therapies or any other plans that the oncologist may have for them. Reaching out to a genetic counselor is usually through referral from oncologists, but for rare cancer patients, it's important that they are reaching out to genetic counselors through a specialty center that they're being cared for.
Great. Thank you so much. Rob, you had mentioned that Life Raft was certainly important for you in terms of your journey. You know, how does a rare cancer patient find that equivalent for their rare cancer, that organization that's going to help guide them? What was your journey in terms of finding Life Raft? And what would you give as advice to rare cancer patients in terms of taking that step? A little bit to what Simran said, which is basically so that the patients can be their own best advocates. So what was your journey like, and what advice do you give to other patients?
Well, thanks for the question. Like I said, I was losing it. I went to my oncologist and asked for crazy pills because I need some I need to be on meds. And she asked me to join a group. And I'm like, no, all right. You know, that's not me. I'm a John Wayne kind of guy, and we don't do things like that. So I joined it anyway. I went and looked online and joined a couple of groups, maybe 3, because I didn't know what to join. I mean, cancer, I'm joining. And so Life Raft was one of them that I joined, and they connected with me, and the advocate for my Chicago area, he contacted me, met with me, and man, I've never been treated better in my life. He really, really treated me like I was his son almost, you know, looking into my cancer, reading the publications, doing the research, Life Raft doing the research for me, and beyond. And what happened? I got a chance to go to the meeting of all the oncologists. Forgot the name, but anyway, I met so many nice people, so many kind people that it really, really, really motivated me and encouraged me and inspired me. And they told two of the main principals there at Life Raft, when I met them at Onco, they told me to get a GIST specialist, one that was in Miami. So I flew to Miami to see this GIST specialist, and he got me on the right track because the other one was just gave up on me. I had 2 oncologists. One didn't know and admitted she didn't know. The other oncologist didn't know and did not admit that he didn't know. And he was treating me. Then when I got connected with the Raft group, they connected me with someone that knew and someone that would treat me. And through genetic testing and through the mutational testing, that's how they found something that would work. They asked me to get the mutational testing, get the genetic testing, and they found something called a variant of unknown significance in NF1. Even though I don't have any signs of NF1, even though I don't have NF1, they got that medication to help me that's keeping me alive today. So it's vitally important that, because we don't know, and we need to be around people that know and that care, that know and care. That way, that is what really, really helped me.
That's great. That's great. And I'll also add into terms of, for those who are watching this on Rare Cancer Day, NORD can be a big resource also. So if people feel that they don't know what organization to go to, NORD can certainly direct them towards organizations in the rare cancer area like Raft that could make a big difference there. A question for all of you, but Simran, I'll start off with you, which is, we hear a lot in the rare cancer about the disadvantage that people have in the rural communities. They get diagnosed maybe in a community hospital, people who have never heard of a certain rare disease. They often are not then brought up to a major academic institution, et cetera. But, if you look at geographically, those disadvantages, maybe even economically, how can this all delay the diagnosis or the impact of medical care? Simran, some comments from you on that?
Yeah, I certainly agree. Obviously, this can delay if you don't have access to the right centers with the right expertise, the right testing, as we just discussed. That can delay diagnosis. Maybe the better thing to talk about, though, is really about what we can do about it, which is, I think there's a responsibility of these academic centers to build communities of practice. So what we do is we sort of have, for example, a hub and spoke model where the patients can see us and make the effort to travel to see us before COVID, and then we can work with their local oncologists and provide guidance so they can get treatment cared as close to home as possible, so that if the treatments are available close to home, they can still get their treatment close to home. It's sort of a win-win situation. It allows us to be able to see the patients. It allows the local treating doctors to feel comfortable that someone's also involved who's an expert on this rare cancer. And it makes the patient feel better in that they know that there is a team working with them and for them, but they also don't have to spend a lot of travel time. I will just add, one of the very few benefits of COVID has been the introduction of telemedicine and virtual care on scales that we have not seen in healthcare before. And I would say for rare cancers, this has been probably an advancement because we have been seeing a lot of patients from far distances away now virtually, at least for their first consult, and we can participate in their care and help improve their care. And this again provides for a model that's designed around the patient, where they can actually have a caregiver or a family member or a friend in the room with them at home, in the comfort of their own home, and start asking questions, and then the network can be built around them. So there are ways to get around it. We just have to sort of think outside the box a little bit.
Great. Thank you. Margarita, from your perspective, same question. And again, I know one of the beauties of the NCI and the Rare Tumor Initiative is that it's free. The counseling's free. People can come. And I know we just had a gathering of fibromyalgia patients, believe it or not, even during COVID, where we were talking about what the advantages of our genetic and genomic counseling and the NIH, the NCI. Do you find that people can find your program easily? It certainly seems to address people from an economic need, that this is something that they can gain. But any comments there in terms of, how to address, again, those who are either economically, in a challenge or geographically?
Yeah, I think so. There's 2 points to it. One is that it's important to also address not only the economic status of the patient, but also the cultural difference, because we know from past studies that there are differences in or lack of communication in culturally different communities. There's also a significant difference in health insurance coverage in this group. So it's important that we address that for rare cancer patients. I believe that at least in the genetic field, genetic counselors and geneticists that specialize in rare tumors like me, we have the responsibility to reach out to other centers that do not specialize. So exactly as Dr. Singh said, the people who are specialized need to reach out and be available. We want to be a resource for all oncologists that treat rare cancer patients. So I believe that the NIH and the NCI provides that. We want to be a template for people to either follow us, reach out to us, and we hope that we are communicating that clear. And I want to use this venue to let all rare cancer patients know that we are a resource for you and for your physicians in educating for treatment, genetic testing, and preventive plans.
Great. Rob, from your perspective, the same question, it sounds like you probably help to mentor folks who are in rural communities, cultural, economic challenges, et cetera. Any, additional words of advice there in terms of best ways to make sure that who they actually see as frontline are actually giving them the information that they need? And is there a checklist, for example, that you and your groups hand out or that should be given out? So what kind of tips can you give folks in that situation?
Yes, we do have a checklist to give guidance if your doctor or oncologist is one that could treat be successful in treating your cancer. But one of the things I think is that some doctors, just like attorneys, at some firms, it's required that you do some cases pro bono. And I'm not saying that doctors should do pro bono, but there might be maybe a commitment needed to try to. I'm going to reach out to a couple folks in rural areas that's going to be on my patient list that has the insurance and everything else, but I will pursue it. Because some of those, like myself, the suggestion was to fly to Miami. If I wasn't able to do that, I would have been in trouble. So if they can do this virtually, because we can do it virtually now, and then have them in the hands of an oncologist that's local to them, I think that would help if that was advertised more, the virtual appointments on specialists in certain cancers.
Yeah, great.
But I do want to stress the importance of genetic testing and that we emphasize that, because it just tells them if their family, if there could be an issue with their family in terms of their genetics, and also it can save their life.
Great. Thank you, Rob. One of the things that NORD is trying to address too is educating healthcare professionals, particularly in the community area. And also they've just started a CME series that will be, next section I think is launching in December 2021 and 2022. The reason I bring that up is a question, again, I'm going to go across the board, starting with you, Simran. What's the best way that hospitals or patient organizations like those that I run can help educate physicians, particularly community physicians who may not have the experience diagnosing rare cancers, but might be seeing a patient for the first time? So how can those organizations help in the education process?
I think part of it is building connections. So my experience has been those oncologists or those healthcare providers that are seeing a patient, and the majority of them are happy to be part of that patient's care and to provide that care close, but they want also to have the specialist involved in their care. But sometimes they don't know where to turn. They may not know where the nearest center may be, where in fact, that they can partner with the specialists. So I think it's important for these centers of expertise and excellence to do outreach, to work together with NORD and partner together with patient organizations as well, to sort of get the word out and to help build these networks. I think that's really key, is building networks where people are working together to provide the care for the patients, because that's really what patients want, and that's, I think, in all of our best interests.
Great, thank you. Margarita, any comments from you in terms of the same question as to how do we better educate physicians in this area?
Yeah, I think exactly what Dr. Singh said is to establish networks, but especially also partnerships with other professionals and with patients. And that's what the NCI Connect and NCI My Part, which is the Moonshot initiative at the NIH, is trying to do, which is establish partnerships with other oncologists, but also have the patients involved. And in terms of the genetic initiative, we try to educate patients on how the genomic and the genetic testing can benefit, change their treatment, or help their relatives too. Also, we, have some initiatives for global campaigns where we educate patients and try to reach to more rural areas and to culturally different and underserved populations. So
Great. And Rob, to you also, we have about 5 minutes here, gang. So any comments on that same questions in terms of, I'll say particularly with your experience, how hospitals or patient organizations can help educate physicians in this area?
I think there needs to be a synopsis or briefings on certain cancers, because if a doctor has loads of patients and family and things of that nature, it's difficult to do to keep up with the latest things that are going on with, and you have patients with different kind of cancers. So if there was a way that there could be briefings or small information concerning breakthroughs that are in cancers, or what others are thinking and what others are doing, then I think that would help the doctor, that they could go and then if they wanted to read further, they could look up that publication and read more deeper into it. So I hope assist those doctors as much as possible, because they're on the front line, and I know it's challenging, especially in the rural areas where they have sometimes twice as many patients, given that there's twice as many people sick in that area. And then I think that we need to discuss and take the time to talk to people about, not at them, but talk to them, and get them to establish a relationship with them, which would draw them in, and they would be more apt to listen and more apt to trust those that are trying to help them.
Great. Thanks, Rob. Team, any final thoughts from each of you before we wrap up? This is, by the way, this has been an excellent discussion, and certainly I'm learning a lot. Even though I run several foundations, it's really quite helpful. Simran, any last minute thoughts for you before we wrap up?
Yeah, no, I just want to thank you very much for organizing this and for helping create awareness. I think these sort of panels are much like we talked about. This is sort of what needs to happen. It is outreach and this sort of communication going back and forth. And I think it's really great that NORD and other patient organizations are becoming more involved. And this is the wave of the future in medicine, is partnerships with patients rather than being told what to do. It's working together to try to find these solutions. And I think it's nowhere more important for industry, patients, partners, physician partners to all work together as it is with rare cancers.
Great, thank you. Margarita, any last thoughts?
Just very grateful to be here for this opportunity. I think communication, establishing networks, reaching out, forming partnerships with patients and physicians is important. And I just want to make sure people know that we all believe that there's hope. If we look 10 years ago, genomic medicine, genetic testing was not able to do the things that we can do now. And 5, 10 years from now, we will probably be able to do many more things that we don't think we can do now.
Great. Thanks so much. And how about you, Rob? Any last thoughts?
I just want to thank you guys for having me here. I really appreciate it. To those that are in the fight with me, I say fight. Do your best. Listen to your doctor. Make sure that you have a specialist in your area of cancer. Join a group and fight this good fight. And things can work for you. You can make it. It's not a death sentence. You can make it, but you have to do the best you can in order to accomplish that. One thing quickly. My thing is I'm praying that the doctor does his best. I'm asking God to do his best, and I'm asking myself to do my best. And that's how I fight the fight.
Great. Excellent last words there, Rob. Thank you so much. So everyone, I'd like to remind you that we will be sending the recording of this webinar to everyone who registered for the event. You are welcome to share the recording with anyone who you think might find it helpful. Again, I want to take a moment to thank our panelists, Dr. Singh, Dr. Regatta, and Mr. Taylor, for sharing your expertise and experiences you have with us today. I'd also like to extend a thank you to NORD and the Rare Cancer Coalition for their support of Rare Cancer Day. At the conclusion of this event, you will be receiving a short survey about this webinar, and we encourage you to complete it. Your responses really do help NORD develop future educational programs. Thank you again, everyone, for joining us on this Rare Cancer Day webinar, and I hope you enjoy the rest of your day. Goodbye now.